Welcome. I'm so glad that you've chosen to be with us again today for Module 3 of Trauma-Informed Practices for Schools, also known as TIPS. Today we're going to be talking about academic impact and the result that trauma has directly on children in terms of health outcomes and also academic incomes. You may have noticed that the background that I have on the slides are a bunch of connected dots. And I really love this imagery because it reflects to me two things: the neurobiological realities of how thoughts are connected through our synapses, and then the results of that through folks who don't understand maybe how to redesign their brains in ways so that their outcomes match the results that they would like in their lives. Our goal is always to help people and assist people to get to a point where they can live their best lives and be as successful as possible in every moment of their lives. So we do that with lots of tools. And again, we've been delving in to what are the things that I can look for in my classrooms and when I'm working with parents and adults that would clue me in that I'm working with someone that's traumatized. These things are linked. And so today we're going to really look at how those things are linked using specific data from Ventura County that is collected at the statewide level and how that impacts marginalized groups, in particular, looking at suspension rates over time as well. I'm going to quote one of my teachers now who said that trauma explains the behavior. It does not excuse it. And this is an important fact for us to consider. We know that teachers like yourself and social workers, therapists are under a tremendous load presently. And I want to thank you for your service to the children and for continuing to invite those kinds of conversations and bring into your own life learning that can help you really recognize what's truly going on with a kid in your class before we go to discipline or worse, expulsion. The other quote from today is that I really want to talk about here for just a second, that trauma is not the child's fault. It's not their fault that they're traumatized. They are simply reacting and showing us symptomology that shows us what may have happened, but more than that, the resulting messages that they got about how to get their needs met. Our job is to then turn that around. And how do we do that? Well, we teach new behaviors. It's not enough to understand the modalities. When we put them into place, we can see those real life results. I know that personally because I've done this work. You may look up and see on your screen the background, which is really about neuroconnectors and reminding us that those messages that are hardwired in our brains about how the world works, how people are, what we see, the lenses through which we see different types of human beings is really important for us to understand. We call those things what is formed after time, muscle memory sometimes. They're not really muscles, they're neuroconnectors, but they build up actually a sheath over time and memorize certain responses. So the brain will go to that connector in that moment. So again, children can't be blamed for this and shouldn't be blamed for their behavior while it is not okay in the classroom. That's for sure. We can look at what is it and where is it actually coming from? How do we change those messages for children? And how do we teach them different ways to be in real time so that they can be successful? We call those ideas about how the world is and how it treats us, how we see things, paradigms. And so what we're really looking for underneath all of this is to create paradigm shifts so that folks can access and think about, if this thing isn't working for me, how do I change that up? What can I do? We're still looking at basic information at this point in Module 3. And first, we're going to start with Dr. Nadine Burke Harris, who worked in California as a Surgeon General and was specifically appointed as a Surgeon General so that she could bring this trauma-focused lens to California in general and California schools. She also worked with probation departments, et cetera, and we really want to celebrate her today. I think this is an exceptional video. I hope that you will find lots of information from it. She does talk rather quickly and it's loaded with data. So get that pen and paper out if you don't already have that. get ready to take some notes, and then we will move into looking at specifically in Ventura County how this plays out in the children that you know and care about in your schools. So let's move now to Dr. Nadine Burke-Harris.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer, and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or a packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California, and together we opened a clinic in Bayview Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle, and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, Dr. Burke, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand, better than we ever have before, how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior, and that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed. So for me, this information threw my old training out the window, because when we understand the mechanism of a disease, when we know not only which pathways are disrupted, but how, then as doctors, it is our job to use this science for prevention and treatment. That's what we do. So in San Francisco, we created the Center for Youth Wellness to prevent, screen, and heal the impacts of ACEs and toxic stress. We started simply with routine screening of every one of our kids at their regular physical, because I know that if my patient has an ACE score of 4, she's 2.5 times as likely to develop hepatitis or COPD. She's 4.5 times as likely to become depressed, and she's 12 times as likely to attempt to take her own life as my patient with 0 ACEs. I know that when she's in my exam room. For our patients who do screen positive, we have a multidisciplinary treatment team that works to reduce the dose of adversity and treat symptoms using best practices, including home visits, care coordination, mental health care, nutrition, holistic interventions, and yes, medication when necessary. But we also educate parents about the impact of ACEs and toxic stress the same way you would for covering electrical outlets or lead poisoning. And we tailor the care of our asthmatics and our diabetics in a way that recognizes that they may need more aggressive treatment given the changes to their hormonal and immune systems. So the other thing that happens when you understand this science is that you'll want to shout it from the rooftops, because this isn't just an issue for kids in Bayview. I figured the minute that everybody else heard about this, it would be routine screening, multidisciplinary treatment teams, and it would be a race to the most effective clinical treatment protocols. Yeah, that did not happen. And that was a huge learning for me. What I had thought of as simply best clinical practice, I now understand to be a movement. In the words of Dr. Robert Block, the former president of the American Academy of Pediatrics, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And for a lot of people, that's a terrifying prospect. The scope and scale of the problem seems so large that it feels overwhelming to think about how we might approach it. But for me, that's actually where the hope lies. Because when we have the right framework, when we recognize this to be a public health crisis, then we can begin to use the right toolkit to come up with solutions. From tobacco to lead poisoning to HIV/AIDS, the United States actually has quite a strong track record with addressing public health problems. But replicating those successes with ACEs and toxic stress is going to take determination and commitment. And when I look at what our nation's response has been so far, I wonder, why haven't we taken this more seriously? You know, at first, I thought that we marginalized the issue because it doesn't apply to us, right? That's an issue for those kids in those neighborhoods, which is weird because the data doesn't bear that out. The original ACEs study was done in a population that was 70% Caucasian, 70% college educated. But then, the more I talk to folks, I'm beginning to think that maybe I had it completely backwards. If I were to ask how many people in this room grew up with a family member who suffered from mental illness, I bet a few hands would go up. And then if I were to ask how many folks had a parent who maybe drank too much, or who really believed that if you spare the rod, you spoil the child, I bet a few more hands would go up. Even in this room, this is an issue that touches many of us. And I'm beginning to believe that we marginalize the issue because it does apply to us. Maybe it's easier to see in other zip codes because we don't want to look at it. We'd rather be sick. Fortunately, scientific advances and, frankly, economic realities make that option less viable every day. The science is clear. Early adversity dramatically affects health across the lifetime. Today, we are beginning to understand how to interrupt the progression from early adversity to disease and early death. And 30 years from now, the child who has a high ACE score and whose behavioral symptoms go unrecognized, whose asthma management is not connected, and who goes on to develop high blood pressure and early heart disease or cancer will be just as anomalous as a 6-month mortality from HIV/AIDS. People will look at that situation and say, what the heck happened there? This is treatable. This is beatable. The single most important thing that we need today is the courage to look this problem in the face and say, this is real, and this is all of us. I believe that we are the movement. Thank you.
So now that we've heard about health outcomes over time, we can use that to see that a kid standing in front of us may be experiencing traumatic events in real time or have experienced traumatic events that have landed for them in a way that they are creating hardships for them in terms of their health. So if we can learn to recognize what those things are, as Dr. Burke-Harris said, we can understand that there might be a direct link to trauma in those cases. So when I meet a child or an adult who has asthma, who may be obese, who is experiencing other kinds of health outcomes, maybe they have ADHD or some other learning disability, or they have hidden disabilities that they tell me about, I look at that and I pay attention to what is actually happening there with that person and then how that might tie directly to trauma that they experienced. Nadine Burke-Harris said that we can make generalizations about people when we know that they have an ACEs score of 4 or more. I'm hoping that you took the time to take the ACEs. I'm hoping that you took the time to take the resiliency factors, which was on your Padlet link in the last lesson. When we look at the ACEs and we know that someone who has a score of 4 or more, and we can learn these things through just listening and conversation to people, we can know beyond a shadow of a doubt that statistically, they are 4 times more likely for this. They are 70 more times likely for that. And we can look for those links and those clues with that person. Now, in my junior high school experience, I had a teacher named Mr. Sussman who was a science teacher. Mr. Sussman brought me in one day and had a conversation with me. And he said, I've heard you say things like that you're stupid or that you're dumb. I've heard you say that you'll never amount to anything. He had been listening to me. Now, he didn't go into a diatribe or a PhD dissertation about why that might be true. Instead, he said, I want to give you a test, and I want to find out what's actually true. What I know retrospectively that Mr. Sussman knew is that I had received messages at home that I was in fact dumb and incapable of learning at a high level. Well, those messages were wrong. And he recognized that because he watched me and he knew that I was capable of learning. So he had me take an exam about how high my IQ was. And then he pulled me back in the room afterwards and said, you actually have a very high IQ. There's reasons why you might be struggling in school, and we're going to look at that. My own personal hidden disability is that I struggle with memory in terms of memorizing big documents. And so he sat down and he gave me some tools about how to overcome that. I went on to go to college, and after that to receive an advanced degree. I am so grateful to Mr. Sussman. And why is this important? Because he was a resiliency factor for me. He didn't develop a long-term ongoing relationship with me. He just took a day and sat down with me and told me that it wasn't true. I wasn't dumb, that I was in fact very capable and smart. And this changed the trajectory of my life. So it's the reason why we have to look at and pay attention to these things that were going on. I already had asthma. I was already obese. Even though I was very, very athletic, my parents had me on a very strict diet all the time because I struggled with my weight. These were 2 clues. When we look at those things and think about those clues, then we can start to connect the dots. It's not to make a diagnosis. I'm not inviting that. That's not your job. It's just to pay attention to clues and then start to ask different questions and listen to what these kids are saying about themselves. What have they learned is true about the world? Can I shift that for them? We know that foster youth are suspended 5 times the rate of all students and more than any other student group. When we look at this, we want to ask why. Well, I know the why. Because these kids are seriously traumatized. They've been moved. They have attachment issues going on. They have experienced some kind of hardship in their home so that they have actually been removed and placed in foster care. My goodness gracious, it's obvious that there are these issues there. So let's take a look at what we know in terms of outcomes for foster kids and homeless kids while in school, just as a baseline. And let's start with the foster kids. During the 2021-22 year, the information that we have based on CDE Foster Youth in California Schools, a great resource in the bottom right-hand corner of your screen, is that there was actually quite a dramatic rise in chronic absence rates for kids. Now, of course, this was during COVID, and that is something that definitely impacts participation in school and absence rates. And we look at this with that lens when we look at COVID as an example. COVID is a traumatic event for all of us. It was and remains so. We look at the fear that it engendered, the change in our social normalities, how we were dealing with people, being in lockdown, all of those things that really shifted for us. And the impact that it had on foster children was really, really big in conjunction with all of the other things going on. When we look at this also in terms of homeless kids, we also see a dramatic jump. And then we see a dramatic jump in all of these other categories during those initial COVID years. And so we can attribute some of it to that. But as we study this further and look at what is true today, our hope is that those numbers will get better. And we want to ask the question, why is the kid absent? What is happening? Where did they go? Are we paying attention to those different tells about a kid starting to not show up in our class? And how can we mitigate that? When we look at suspension rates, it tells a similar story. Now, we look at foster care kids during that same time period, 2021-22, and we see a slight decrease, but this is catastrophic. This is a number that we really need to change and ask questions. Why is this child being suspended? What have we done? Have we had an EAP? Have we brought in therapists? Have we asked the therapist to actually address what might be going on with this kid at home? And I realize as I'm saying this, that teachers are bombarded with more and more work and less resources right now. What we do know is that those resources are there in Ventura County, and it's a matter of pointing those children and getting the families involved. We really need to pull in the parents, the guardians, the grandparents, the foster care folks, the caregivers of these children, and get them involved and start asking better questions. Now, this number gets more interesting when we look at suspension rates for foster youth compared to all students. And then we bring in the intersection of race. Now, we all know, and I'm sure that you've taken classes that spell out the disparity between children that are in foster youth and regular students according to race. When we look at these race charts, we've got race and ethnicity of all students. We've got a 1.2% enrollment for African American kids, yet we've got a suspension rate of 2.6. We want to ask ourselves, why is that? What is happening here? Hispanic or Latino kids, 59.6% cumulative enrollment rate. Looking at suspension rates, again here, 73.3%. Why is that? When we look at that in comparison to the other data of kids, it's undeniable. White kids, it's less when it comes to suspension. So a part of this also is us having the courage and willingness to examine our own internal biases about people of different races and ethnicities, genders, gender identities, sexualities, abilities, etc., and really examining that and taking a deep dive. Tons of research out there about how our biases impact those kids. Why are we suspending this kid? Are we treating children equitably? We don't want to treat children equally. Equally doesn't work. We know that. We want there to be equity. And what that means is, gosh, I'm noticing with this particular kid that there's something going on with them. And I'm going to slow it all down and do a little bit of digging here. This is something that we need to examine and look at. And I'm going to pull in some folks who know more than me about this kind of thing, therapists, maybe the principal, the school therapist, etc., and talk to them about what might be going on with this kid. What do we know about their family or where they are, their stability, their access to food even? What's happening with this child? When we move to suspension rate of foster youth, so we started with all students. And when we look at then foster youth in particular, we see a dramatic jump. African Americans disproportionately in foster care. It goes from 1.2 to 7.2%. When we look at the percentage of suspensions of those foster kids in particular, we can see a dramatic jump. Going from here to this, it's a dramatic jump. So I would want to ask myself, if I have children in my classrooms who I'm working with in a therapeutic environment, are those kids actually having access to and getting the help they need so that they can actually look at and examine what are these behaviors that have become maladaptive in the classroom, and how can we actually keep them in school while keeping peace in our classrooms? Some of you might be thinking, what can you know about this? Well, I started a project and a program in a juvenile detention facility that was actually a camp where we were able to reduce violence in the classrooms by 80%. Now, this was a huge outcome, and it took a lot of people. We involved everybody, the cooks, the clothes washers, the folks that had direct supervision over them, the management team, the therapists, and most importantly, the schools and the teachers. So I know that this can work when we start to actually look at what's really going on for this kid, what's really happening underneath that anger, and then mitigating those things on the front end. When we look at the number of African American kids, and when we look at the number of Hispanic and Latino kids as well, it's astonishing when we compare them to the numbers that are not foster youth, with this exception. Why are Hispanic and Latino youth disproportionately in foster care as well? We want to ask ourselves those questions, and those will point us to the answers we need to determine what are the behaviors and the belief systems, the paradigms that are wrapped up in this kid's inability to be successful and in fact get kicked out of the classroom. We don't want that. Then when we look at two or more races again here, higher numbers, 24% and then 14% respectively, looking at suspension rates. And then two or more races, again, a high number, 2.8 in terms of cumulative enrollment versus 3.7 in terms of those of two or more races who are suspended. So what can we do about this? Really doing an analysis when the kids are coming into our classroom and learning a little bit about them. What is going on in their home life, what's happening with them, and a lot of that we can get through the files and have access to as instructors before we ever even meet the kids. So we can have an idea about how to really work with this kid, to pay attention to them, and to help them overcome these stories that are impacting their lives in really traumatic ways. This is again Ventura County School District specific. When we look here again at suspension rates of all students, now this is 2021-22. We've got disproportionately high numbers of African American, disproportionately high numbers of Hispanic and Latino, disproportionately high numbers of white kids, which is really interesting here in terms of suspension rates. But we'll notice that when it comes to people who are brown or black, the suspension rate actually goes up, whereas the white suspension rate goes down. We have to ask ourselves, what is that about? What is actually happening with that? Could this potentially be bias? Are we paying attention to what these children are telling us? I teach an 8-hour class about implicit and explicit bias, and it's so powerful in how it works inside of ourselves, how we have different expectations of different kids in the classroom. We know that African Americans, especially African American boys, are suspended at higher rates, African American girls at 5 times the rate of white girls in school. Why is this? Let's ask those questions. When we look at suspension rates for foster youth, we see another compelling story here. The percentage of children that are suspended higher than the number of those who have cumulative enrollment. When we look at that for African Americans. When we look at the piece for Hispanic, it tells the same story. So how can this be true? What is going on? When in fact for white kids, the number goes down. So why is this happening? These are the big questions that we must ask ourselves. Are we treating our students in equitable ways? So this is a key component when we talk about diversity, equity, inclusion, or what we talk about DEI. Am I being equitable in the classroom with people who are different races, ethnicities, genders, sexes, all of the ways that we're so beautifully different? Am I treating everyone with equity and adjusting my style so that I can really work with that person and be effective with them and give them what they need? What do we know? That typically there's little to no training for educators around trauma and trauma education. When we think about this, we've got PP versus Compton in the Unified School District, which is a court case that actually came out that said that instructors and educators must be trauma informed. So that's why you're here today. I'm hoping that you're here today for a bigger reason, because it opens your heart and that you want to understand very real issues being faced by these kids in your classrooms. Of course, there's communication challenges within systems. We all deal with that in our workplace. I'm not making light of that. It makes your job harder. And here you are today in a specialized class learning about how you can actually implement these things in your classroom. Guess what else I found in my study? That staff were happier when fights went down, when kids were expelled from class less, that teachers and staff felt safer in the environment and enjoyed their work more. Furthermore, they were able to do more with the kids, offer more programming, more events, all kinds of creative things. And we actually found that we had to do a new initiative to come up with more things to do with them in terms of programming. Misdiagnosis behavior and challenges in survival strategies. Again, we've talked about this throughout, right? We're misdiagnosing behavior. We're not seeing that the behavior is a symptom of what's happening for these kids at home or what has happened to them historically. These are survival strategies that have worked for them over time. So how do we change those survival strategies to be things for people that are actually tools that they can work with and use? It's noted here that trauma was recognized also as a disability in this Compton Unified School District case. And when we think about that piece, we want to know that trauma is actually a disability for people and is recognized in the DSM-R as a mental health issue that people need help with. So we want to really be as informed as we possibly can around these issues. And I'm so grateful that you're here today in this space with learning. So let's recap a little bit. We talked about how, as Nadine Burke-Harris explained, that someone with a 4 or more on the ACEs is really a big tell for us about potential outcomes. But the power is that if we know what could happen, we can change that trajectory by intervening in that child's life. Miss Hoffman was another teacher that I had. She was a social studies teacher. She saw that I was very interested in her class. I don't know what she knew. I've never been able to have a conversation with her. But Miss Hoffman asked me between classes and after school to help her set up her classrooms. And we set up those classrooms with maps and different kinds of learning strategies. And she taught me about classroom management and how to do things. What were learning styles? It was one of the greatest times I had. She was so wonderful. I look back on that and I would love to be able to sit down and ask her, why did you do that and what did you know? I feel sure that she knew that she needed to give me a little bit of special attention. And what happened from that? I became a sociologist. I went to college for a sociology degree. I'm now a teacher professionally. The things she taught me never left me. And what did it cost her? She could have set the classroom up alone. It might have been a little more efficient. But she took time. And she really explained to me the importance of different cultures and why it was important to understand where people came from. And that got me interested in so many other things. I'm forever grateful to her. That is what resiliency is. That is the resiliency factor in that place. Thank you, Ms. Hoffman. So we finished our third piece here, and now we're looking at moving into Module 4, which is a practice session around ACEs and urban ACEs and looking at maladaptive coping strategies. So we're going to actually get a little deeper with ACEs. I've mentioned several times the importance of memorizing those 10 things so that you can have them as a starting point for yourself in your mind as you're listening to people and really hearing what they have to say. The next level resources for you are going to be found under the orange section. We have our little orange apple there in the Padlet link. I'm hoping that you're able to pull the Padlet up on a larger screen than your phone so that you can really look at all the resources there and see it. I'm inviting you to go and look at that and spend a little bit of time checking out those resources for yourself. I'm hoping that you'll spend a little bit of time looking at that. And if you haven't taken the ACEs or resiliency assessments, I invite you to do that before our next lesson. It's really important that we look at ourselves first and so that we can have a felt understanding and a lived experience of these things. So those can be found there on the Padlet, easy to link to. And again, for this session, that is the orange. What we're going to use as a resource color for the next session is green. So if you haven't taken the ACEs or looked at the urban ACEs yet, please go to the green section where you'll be able to find those pretty easily on the left-hand side. I think it's in the first or second column. Also, if you're needing more resources at this point, you can reach out to Foster Youth Services. We also added a huge section from Ventura County Office of Education, which is resources that you can just print out and have available to you at your desk. And then the Homeless Education Program, we have their contact information there. So I look forward to our next module, which is practice, where we're going to be actually looking at some memorization around ACEs and urban ACEs and maladaptive coping. I hope you're going to have a great rest of your day, and I look forward to seeing you. Take care.